Thank you. Now that we're all awake. So I am Lieutenant Colonel Story. I am the Sustainment Brigade H2F Dietitian and your narrator today. I do want to give a shout out to our 1st Brigade H2F team. They can stand up, make themselves known. We're leading a great yoga session this morning. So show of hands, did anyone attend that this morning? Hey, don't be shy. It was great. You know, I like the yoga occasionally. It helps make me feel a little bit more refreshed, helps me center, helps me work on my breathing, right? So it is a nice component or something different to do on a regular basis. So thank you all for attending, and I'm glad to see that we have a mixture of our audience today. This is our first in a quarterly series focusing on injury prevention and performance optimization. And today we chose to focus on women's health to celebrate Women's History Month. So it is also National Nutrition Month, so near and dear to my heart as a dietitian. It is also Athletic Trainer Month, so if you are a dietitian or an athletic trainer, please stand up. They didn't know I was going to do this, by the way. And thank them. We have note cards at each of the tables. Should you wish to make comments, please leave them with one of the H2F team members. We're going to be here throughout the seminar, throughout lunch, throughout the day, because we will have our round-robin tables and installation resources, as well as annual EO training this afternoon from 13 to 1600. So if you are deficient in your annual EO, please stay a little bit longer. Make sure you knock that out. And Colonel Bronto has some t-shirts out there as well for Women's History Month. Okay. We will pause briefly between each speaker for about 2 to 3 questions. Okay, our timeline is a little bit short, and I get it. We're all very busy, and we have things to do and places to go. So we'll take a maximum of 3 questions based on time. If your question does not get answered, please use those note cards. Write that question down, or find us afterwards. If you write it down, leave your contact info so we know how to reach you, and just give it to one of us H2F team members. Okay. Likewise, for those of you in this room, we do have a free lunch opportunity immediately following this. There will be a boxed lunch provided. And due to time, we're not going to take scheduled breaks, so please, if you need to get up, use the restroom, feel free to do so, get coffee, take a phone call, please use the lobby for that, just so we can keep it rolling. Photos are welcomed, and we do have PAO coming around. And lastly, some of our topics may be uncomfortable for some, such as pelvic floor rehabilitation. However, these are very important topics that have significant implications for our soldiers if not addressed properly. So if you are uncomfortable, it's okay if you need to leave. No judgment here, okay? So without further ado, I'd like to open briefly with a quick introduction to holistic health and fitness. Next slide. Oh, there are some of our topics. Go ahead. All right. Who here has heard of holistic health and fitness before? Okay. You might have heard about it, right? But you don't quite maybe fully understand what it is. Holistic health and fitness is our Army's premier soldier readiness platform. H2F formalizes the training and recovery through our performance teams, who are comprised of our program directors, our physical therapists, occupational therapists, dietitians, athletic trainers, strength and conditioning coaches, and though they're not an organic asset, we do include our beloved chaplains as part of the spirituality component. As we continue our rollout throughout 1ID, you will see more of our great team members coming through in all 4 of the brigades. Okay. So similarly to Operation Victory and Wellness and the Commander's Ready and Resiliency Council, we cover certain domains: the physical readiness, nutritional readiness, mental readiness, and for that spiritual readiness. We believe that spirituality is the foundation of who we are, right? So if you don't know who you are, what drives you, etc., that's the spirituality component best addressed by our chaplains, as well as our occupational.
Good morning. Can everyone hear me okay? I'm used to yelling, not using a mic. All right, so my name is Captain Megan Balcom. As Lieutenant Colonel Story introduced me, I'm 1st Brigade's H2F physical therapist. We're going to be talking about injury prevention. Oh, sorry, I'm confused. Next slide. Perfect. Alright, so objectives that we're going to talk about today. We're going to review the Baton score and interpret your results. We're going to explain what relaxin is and how it affects our joints and injury prevalence. I'm going to describe actionable goals to preventing injury. And then lastly, we'll talk about discussing bone mineral density and how to prevent osteoporosis. Next slide. Perfect. Alright, I love participation in my classes. It keeps everyone awake and it brings about some thought. So feel free to raise your hand or shout it out. What does hypermobility mean to anyone? There's no wrong answer. Participation, yay! Very flexible, perfect. I like that answer. Don't worry, we'll go over all of these. I'm trying to just get a baseline of what everyone knows. Does anyone know what joint stability means? There's no wrong answer. Come on, you guys, we got caffeine in the back. I believe in you. Someone shout something out. Just give me a guess. Perfect. I like it, ma'am. How strong your joints are. Probably no one has heard of this one. Has anyone heard of the Baton score? That's all right. We're going to go over that one. I don't expect you to know that one. Who in here has heard of relaxin? What does relaxin do back there in the back?
Allows your joints to move more freely.
Perfect. Allows the joints to move more freely. Does anyone know one way to prevent low back pain among the female population? Core. I heard core. That's the best answer. The physical therapist in me loves that answer. Awesome. How do we prevent hypermobility injuries? Any guesses? Strength. I heard strength. I like that answer. Don't worry, we're going to go over all these. I'm just getting you guys thinking. Participation, yay. Last one, does anyone know what osteoporosis is? Low bone mineral density, perfect. Does anyone know who's most susceptible to it? Old people, the geriatric population. Good work. All right, let's talk about all this stuff. Next slide. All right, hypermobility and the Baton score. We're actually going to do this so everyone's going to see if they are hypermobile or not, okay? So hypermobility by definition is excessive laxity of multiple joints that may lead to joint pain or injuries due to decreased stability. Okay, so I like to explain hypermobility as think of a train on a train track. If it's running nice and smooth, we have good joint stability. If it's kind of wobbly, the train's kind of all over the place on the tracks, it's probably going to wear and tear on the wheels and the tracks because of all that instability. Does that make sense to everyone? Perfect. And then the Baton score is just kind of like a medical screening tool that we use to see if you are hypermobile, if you have that increased movement of your joints. And then to interpret these results, anyone with a 4 or higher out of 9 is positive on the Baton score, okay? So, participation. Everyone go ahead and stand up, and you're going to take off your blouse if you're comfortable with it. All right, so we're going to do all 5 of these tests. So test 1, you're going to place your hands flat on the table, and you're going to try and extend your pinky backwards with the other hand. If your pinky goes backwards greater than 90 degrees, that's 1 point. You're going to try on both hands. You don't need to crank, you don't need to injure your pinky joint, but if it goes greater than that 90-degree angle, that is 1 point. Test both hands. Perfect. All right. Is everyone done with both pinkies? So greater than 90 degrees is 1 point. If both hands do it, that's 2 points. Next one, we're going to extend our arm. Our wrist is going to be flexed, so down, palm is down. We're going to grab our thumb and try and pull it back to our wrist. All right? If our thumb can touch our wrist, that's 1 point. Go ahead and check on either side. Captain Godin. Godin, are you positive? No? Okay. Is anyone positive that would like to come show the groove? Come on up. It's just a good
learning experience. If you're not comfortable, that's totally fine. But if anyone's positive and they want to show the group so everyone can see what it looks like. Okay, so just raise your hand in the group if you're positive and people can take a look. You want to show us? Woo! Yeah. Thank you very much, I appreciate it. All right, so we did 2 pinkies, we did 2 thumbs. So you have a possible score of 4 right now. Next one, we're going to extend our elbows to 90 degrees. If you hyperextend greater than 10 degrees, that's a positive on each arm. And you can have your battle buddy take a look and see if you hyperextend. Is anyone positive that would like to show the group? Come on up. Captain Godin is going to show us her hypermobility. Oh! Thank you, Captain Godin. All right, and the last movement we're going to check, we're going to bend over, keeping our knees straight. We're going to see if we can place our hands flat on the ground. Not fingertips, but flat on the ground. So we're going to go ahead and try. Keeping your knees straight. Don't hurt your back, please. Good. All right, once you have your score, you can pop your top back on and have a seat. I love movement. We move in every one of my classes. Wakes everyone up. So again, 4 or greater out of 9 means that you have hypermobility, which could eventually lead to an injury if we're not careful and we don't strengthen the muscles around the joints and protect those joints. Okay, so let's talk about how to protect those joints a little bit. First, I want to talk about relaxing. Go ahead, next slide for me. Perfect. All right, we'll get back to how to protect those joints, but next thing I want to talk about that can impact that hypermobility or that joint laxity is relaxin. Relaxin is a hormone, and it loosens and relaxes your muscles, tendons, joints, and ligaments. Okay, so if we have a nice stable joint, but then we have this hormone flowing through our body, we're going to have more mobility around the joints, which increases our risk of injury. Specifically, during our menstrual cycle, relaxin increases the odds of fertilization, and then when we go into pregnancy, which Captain Godin will talk about, it also impacts our joints. Biggest thing, and I believe Ms. Coffey is going to talk about this, relaxin can cause injuries. Specifically, ACL tears are really common during that peak relaxin phase of our menstrual cycle. So if you take a look at this chart right here, CD1 is the start of our menses, and then CD21 to 24 is that peak relaxin phase. So 20 days after our menstrual cycle starts is when we have that peak relaxin, which could lead to ACL tears or other hypermobility injuries. Next slide. All right, so how do we prevent injuries related to this hypermobility? First, we want to improve joint stability. We talked about joint stability at the beginning of the class, right? What is it, or how do we do it? We just want to improve the strength of the muscles around the joints. So if you think about my knee joint, what muscles surround my knee joint? Anyone? Participation? Quads, perfect. Hamstrings? Calves, good job, you guys are awesome. Quick learners. So if I have strong quads, strong hamstrings, and strong calves, that knee joint is going to be really, really stable. It's going to be less likely to sustain an injury. And then weight-bearing activities to create this is a big word, co-contraction of all the muscles in the limb. So if I stand on my right leg, all the muscles in my right leg have to fire to keep me from falling over. So my quads are firing, my hamstrings are firing, and then the muscles on the outside and inside, my hips AB and adductors, they're all firing to do this co-contraction effect to stabilize that joint, right? So that hip joint's nice and stable, that knee joint is nice and stable. So any single limb stuff with upper body or lower body is really going to help that joint stability. And then for my 4 or greater out of 9 positive Baden scale people, this one's for you, avoiding those end range positions.
So we don't want to hyperextend those elbows. We don't want to hyperextend those knees. So if you think about doing a push-up or an overhead press, anything where we're extending our elbow, we're just maintaining a slight bit of joint flexion so we're not popping into that hyperextension. Does that make sense to everyone? I got pictures, don't worry, we'll go more into it. All right, next slide. All right, actionable goals. These are things you guys can take away and start doing today to prevent injuries. I'm going to give you a couple exercises for each joint, okay? Next slide. All right, ankles and hips. I like a lot of single leg stuff. So we have this single leg RDL. If any of these are confusing or you guys don't know how to do them, I'm here, Coach Miner's here. We are here to help you, okay? This is just a couple ones that I like to give. So she's standing on that left leg. Remember, all the muscles in that left leg are firing to stabilize the ankle joint, the knee joint, and the hip joint. Increasing joint stability, decreasing injury prevalence. And then I have a lunge. You could do forward, backwards, lateral, whatever you like to do. A lunge is a single leg squat. Really good single leg work. And then a lateral step up. So she's just stepping up onto the step and then stepping back down. I would recommend some progressive overload, so adding some weight to this. If you're not using any weight, you're probably not going to make enough changes to show those adaptations. Next slide. All right, for the knees, I love a resisted side step. You can steal a band from my office if you need one. I have plenty to give out. Single leg squat, every physical therapist's probably favorite exercise. And then lastly, this one over here is a single leg sit to stand. You guys can try all these out later today. I would make you do them if we had more time, but unfortunately, you just get to look at the pictures today. And I think Ms. Coffey's gonna go over what our knee needs to look like while we're doing that single leg squat and while we're doing that sit to stand. You guys picking up on the theme, a lot of single limb stuff for joint stability? Good. All right, next slide. All right, and then we get to the spine, our pelvis. And I want everyone to be able to figure out where spinal neutral is. So everyone's gonna sit up nice and tall for me. I'm gonna show you with one hand. I want you to put your hand on the smallest portion of your waist and then push down until you feel your pelvis, that bone right there. Perfect. So we're gonna feel what rounded feels like and what hyperextending feels like, so then we know what neutral feels like, okay? So first I want everyone to hyperextend. So you're almost arching your back backwards. Perfect. So a lot of females, I know we're kind of over-exaggerating this, a lot of females sit in this hyperextended position. The spine does not like this position, all right? And then let's go the opposite. Go ahead and round, like you're pushing your back into your chair. Yeah. So not great posture, obviously, but also the human spine does not like this position. Now, we felt what wrong feels like, so let's sit up nice and tall, nice neutral spine. Does everyone feel what a neutral spine looks like? Perfect. This is where we want to be for most of the day and for most of our exercises, all right? Next slide. So a couple of my favorite core exercises, we have the plank. Notice how her spine is not hyperextending. If anything, we do want a slight round so that we're activating our core muscles. And then I have a suitcase carry down here, so she's just holding a weight in one arm, and then she's walking. If you think about me having a weight in my left hand, weight's gonna bring me here. What muscles have to activate to hold me upright? My core muscles. And then a dead bug. Anyone who's probably taken a class with me or Coach Miner has done this exercise before. We're laying on our backs. The biggest thing is we're activating our core, so we're pushing our back into the ground, and then extending that opposite arm and leg. Great exercises for the core. Next slide. All right, shoulders. So, if you couldn't tell, I really like planks. For shoulder stability, shoulder and elbows, we just want to put some weight through those arms. So a plank is really awesome. I love a plank tap, where you're just in a plank and you're just slowly tapping one shoulder and then the other. We could all try this one in our seat, so I'm going to grab a chair real quick. So it's not a tricep push-up, it's shoulders. So I'm going to have my arms straight. I'm going to set this down. I'm going to lift up with my shoulders, not my elbows. I want you to feel the difference. Feel shoulders and then feel elbows. So when we're doing a plank, we're weight bearing in the front. When we're doing this one, kind of weight bearing downward And then that side plank, we're weight bearing out to the side. So we're just trying to activate all the muscles in the shoulder girdle. Next slide. And then last one for joint stability, I just went with wrists. So we just want to weight bear through the wrists. This isn't the greatest position for the wrists because it's in that hyperextended position. So we just want to fist so we're in that nice neutral position. And we can push against a wall to make it a little more complex. We have an unstable surface. You can push against a pillow or a ball. And then lastly, we have a modified plank from that wrist position. Next slide. All right, and then here's for my people who have that 4 or greater out of 9 on that Baton score. So you guys can really see this nice straight elbow. This is what we want. And then you could see this hyperextension of the elbow. So if you think about that train track that we talked about, if we think about putting all the weight on the right side of the train and then going down the track, we're gonna have more wear and tear on the right side of the train, left side's gonna be fine. So that's kind of what's happening to your joints when you're putting all that weight on one side. And then similarly with our knee, you guys see how it's kind of hyperextending here. So we're just trying to avoid those end range hyperextensions because they're not gonna be great for our joints down the road. So how do we avoid them? Next slide. So when we're doing any kind of plank, push-up, anything like that, you guys can clearly see hyperextension here, slight bend in the elbow, keeping that joint nice and straight. And then anything we're doing with our legs, so a squat, a deadlift, a leg press, instead of hyperextending, as that bottom picture shows, we're just keeping a slight bend in our knees to avoid really getting into that end range joint position that our joints don't like. Next slide. All right, last topic I'm going to talk about, osteoporosis. So, it is a loss of bone mineral density that weakens the bones. If you take a look at this picture over here, we have this lovely healthy bone, nice and dense. This orange stuff is the bone that we like, and then the red stuff is kind of that intracellular matrix, like a lot of fluid. And then we have osteoporosis over here. See how it's a lot more fluid and a lot less bone. So very, very weak bone. We already talked about who's susceptible to it, that geriatric population, right? Specifically females over the age of 50 or postmenopausal because our hormones just kind of decrease and then we're more likely to have that lower bone mineral density. The only symptom you're going to have really is if you have a fall, you're probably going to fracture your hip or your wrist. You're not going to know you have osteoporosis until you sit too fast and you fracture your spine. These are real stories, they happen, okay? So it's really important to avoid the osteoporosis. So how do we avoid it? Diet. Diet is huge, and Captain Eberlein will talk about how to avoid osteoporosis. And then weight-bearing activities and resistance training. So any weight-bearing activity, walking, jogging, hiking, anything where gravity is pushing down on our bones is going to be really awesome to prevent osteoporosis. Things that are non-weight-bearing. Swimming, Pilates, or we're laying on our back. So think about standing and gravity is pushing down. And then any type of resistance training. So it could be cables, bands, dumbbells, kettlebells, barbells. Anything where we're putting force through our muscles, that force is also going through our bones and it's going to strengthen those bones and that bone mineral density. Next slide. All right, let's see who paid attention. What does hypermobility mean? Anyone, you can shout it out. Participation.
The ability to overflex a certain one.
Yeah, overexflex or hyperextend. Thank you. Perfect. What is joint stability? I know y'all pay attention. Come on, I believe in you guys. Joint stability.
How flexible are you?
Strength, exactly. Strength around the joints. Does anyone remember what that Baton scale is looking at? How flexible you are, or if you are too flexible, exactly. What is relaxin and what does it do? It's a hormone, perfect. It loosens those ligaments, joints, tendons, muscles. Awesome. What's one way to prevent low back pain in females?
Neutral spine.
Neutral spine, awesome, I love it. How do we prevent hypermobility injuries?
Strength training.
Strength training, awesome, and avoiding those end range positions if we're hypermobile. Lastly, what is osteoporosis and who's susceptible? Women. Low bone mineral density, awesome. All right, next slide. Does anyone have any questions?
So, for soldiers who are hypermobile and have the elbows that go in, right? Hyperextend, dietitian. So when they're taking the ACFT and they're expected to go to, almost end range, but their end range is different, how do they train not to overextend?
Great question.
So Lieutenant Colonel Story's question was in reference to the ACFT when we're doing the T push-up. For anyone who has that hypermobility, how do we train and how do we avoid that position? So ATP 7S22.01 is ACFT grading. It does not say you have to fully extend. The manual says near full extension for the T as well as for that end range push-up. So I'm going to repeat that. You do not have to fully extend. The wording is near fully extended, okay? So we do want to keep that slight bend when we're doing the T as well as when we're in that end range plank position. Great question, ma'am. Any other questions?
So
Yep.
it'll be when you do the leg press, I guess, like that would be near extension then?
Yes. So the question was when we're doing a leg press, is that also that hyperextension? Could you go back to the slide with the leg press, please? Yep. So, red X, we're hyperextending. We're irritating that joint at end range. Green check mark, keeping a slight bend in those knees. This is only for people who are hypermobile, all right? If you don't have that hypermobility, you could extend fully. You don't really want to lock them out. Keeping a slight bend is always the best though. Great question. Any other questions? Yes?
Ma'am, what Army is doing like a preventive medicine for old guys like me, for menopause and osteoporosis. You know that it's a risk, but when you go to the doctor and say, hey, I have menopause or osteoporosis, it's your old bones, don't worry, it's natural. So there is any kind of preventive medicine for osteoporosis implemented by the Army?
Oh, by the Army, that's a good question. So her question was, is there any preventative medicine or any recommendations Army-wide for osteoporosis? I'm not tracking that there are any Army-wide programs. That's a great question. Maybe it's something we should look into. Any other questions?
Say, have calcium and vitamin D on board every day, take a labs done.
So she said calcium and vitamin D.
And vitamin D.
The dietitian's about to go over all that, so I didn't want to steal her thunder. Anything else? Great, thank you so much for the participation. Ms. Coffey is up next. You want to give a 5-minute break? Okay, we're going to give a 5-minute break real quick. About acute angle and ACL tears.
Good morning. Sorry. Good morning. My name is Kimberly Coffey. I'm the athletic trainer for First Sustainment, and I don't really see a lot of sustainment soldiers that I've seen before. Sorry. But yes, so I've been with First Sustainment for over a year now. So a little bit about me. I've been a certified athletic trainer for 11 years. I have a BS in athletic training from Delta State University in Cleveland, Mississippi. I've worked, did I hear a whoop? Oh, Mississippi? Yep. In the South. So this is my first time working in the military setting, but I have a wealth of knowledge. I've worked in the D1 setting, junior college, high school, and in the clinic. So athletic training doesn't change, just the people change. And I played 4 years of basketball, so I know about injuries, and slightly semi-pro in Italy, you know, just a little bit. And I'm married to a Black Hawk pilot, and I have a 4-year-old and a 2-year-old daughter. We're at school right now. So the objective today, I'm going to define, I want you guys to define and understand what the Q angle is in the woman and in the man as well. So we're going to identify how to measure it, and define and understand what the anterior cruciate ligament is, or the ACL, and examine how to strengthen muscular structures to prevent patellofemoral pathology. Sorry about that. All right, so what is the Q angle? Does anybody know what that is? Okay, so the Q angle is a line that measures from the anterior superior spine of the ilium, from the front tubercle of the tibia through the center of the patella. So many words. So basically, does everybody know where their kneecap is, right? So it is an imaginary line that goes from your kneecap to your anterior, to your hips right here. So if you just rock your hips, you can feel where your hips are, and then it's an imaginary line that goes up, and it's measured with the knee fully extended and with the knee fully, flexed at 30 degrees. And I'll have go to the next slide, please. Yes. So right here, this is for the male. Males typically have a smaller Q angle than women, because women typically have larger hips because we are made to bear children. So our hips spread, and then this is why our Q angle is larger, which puts that force going in, or a valgus force, which puts all, like the ACL, the MCL on taunt, which predispose us to ACL injuries and patellofemoral injuries. So what is a normal Q angle? Females with a Q angle between 5 and 14 degrees are considered normal. And females with a Q angle greater than 15 degrees are predisposed to patellofemoral pathologies. And like I just stated, women have larger Q angles than men and larger hips. So that just puts us in an unnatural position. Next slide. So this is a brief video on how to measure the Q angle that I had specialist Ox come in and help me with that. So play that for me, please. Today we're going to measure the Q angle in the female athlete. So first you're going to need a goniometer, and you need to measure the ASIS on the anterior part of the athlete. So I'm going to kneel. I'm going to go ahead and have her rock side to side, so I can identify where her hip is. So it is right here. Now I'm going to take the head of the goniometer, to line it up with her hip here, make sure it's at 90, which it is, and then we're going to find her patella and draw an imaginary line up until we get here, and now I'm just going to adjust the goniometer to where the line is, and now it is measuring at 93 degrees. So she has
Which is a negative, which is 3 degrees.
Which is normal. Anything over 15 degrees is abnormal. It will cause patellofemoral issues or ACL tears or any type of knee pathology. So next we're going to measure with the bent knee. So I'm going to have the athlete turn to the side and have her flex her knee or bend it to 30 degrees. Keep going. Right here. So now we're at 30 degrees. I'm going to have her turn back around, get back to that bent knee position, right until 30, right here. And now I'm going to re-measure again. You have to measure in both planes at 0 and at 30 degrees. So now I'm going to come across her ASIS right here, get right to 90, and now I'm going to draw that imaginary line back up here, and then slightly turn it. So that increased her angle by 2 degrees. So now her Q angle is 95 degrees. So in order to achieve the correct measurement, you have to first measure at 0 degrees and then at 30 degrees flexion. And this is how you measure the Q angle in the female athlete.
Okay, so
So specialist Ox ended up having a +5 Q angle. So where her knee fully extended, it was 3, and then when we bent her knee, it went to 5. So that didn't really predispose her to any ACL tears or anything like that, but it's just good knowledge to know what your Q angle is when you're doing those different positions, when you're performing duty or if you're actually working out. You just need to know where you are in those end ranges. So the anterior cruciate ligament, or the ACL, so it arises from the anterior medial intercondyle eminence of the tibia. It inserts on the lateral femoral condyle. And basically it's in the back of your knee. That's what all these words mean. And it basically is a stabilizer of the knee.
And it stops from anterior translation and inter-rotation and hyperextension. So just as Captain Balcom said, that hyperextension, a lot of people may be hypermobile, so the ACL prevents you from hyperextending fully, which could cause injury. The most common mechanism for ACL tear is hyperextension or a varus force, so planting and cutting. So if you plant and your foot gets stuck and you cut, that's one of the ways to tear your ACL. And when the ACL is torn, most people feel a pop in the back of their knee. Some people think it's their hamstring, but initially you feel that pop and then you feel nothing at all because the blood supply has been cut off. So a lot of people think that like, oh, maybe I just hurt my hamstring or I stretched it, and then they go to run and their knee is unstable and then they collapse. Next slide, thank you. So this is just a picture of a hyperextended knee, someone coming in and giving that force. And right here, this is where the ACL and all the other knee stabilizers attach in the knee. So statistics, what does this mean for the female athlete? According to the BMJ Military Health Journal, the risk of ACL injury in female enlisted soldiers was 0.8 times greater than their male colleagues. So you guys are just predisposed to ACL tears, but we will go over how to mitigate that as well. So according to Northwestern Medicine, women are 2 to 8 times more likely to have an ACL rupture than men. And also women with acute angle of 15 or 20 degrees have an 85.2% chance of higher risk of total ligament tears of the main stabilizers of the knee. So the ACL, the MCL, the meniscus are the most frequently torn. Other injuries associated with an increased Q angle: patellofemoral pain, knee hypermobility, chondromalacia, which is the softening under the kneecap. Patella subluxation is when the patella comes out of socket and then comes back in, stretching ligaments, and sometimes causes injury as well. And of course, the ACL tear. So, with all that knowledge, how do we help your knee so you do not tear it? You gotta strengthen the muscles, which we've already talked about. So, strengthen the quadricep muscles. It helps mitigate injuries and associated pain with an increased Q angle. So, some of these exercises, straight leg raises, you can go ahead and keep going. Hip flexion, extension, abduction, adduction, wall slides, lunges, reverse lunges with hip flexion, and squats, and box jumps. So, I'm going to show y'all this video with a straight leg raise. So when you're performing a straight leg raise, you want to make sure your toe is pointed towards you, activating your quad, pushing your knee down, and raising your leg. And you want to go into end range. You don't want to overextend your leg because you will get other muscles involved. You only want to work your quad, your calf, and your hamstrings. So everyone find a spot on the floor real quick. We're going to perform 3 straight leg raises so you can see how that feels. So go ahead and listen to my instruction. Find a little bit of room. You want to make sure, number 1, that your back is flat on the ground. Make sure you're not hyperextending. Pull your toes towards you. Pull your toes towards you, making sure you're activating that quad and raising up. Good, good, good. Okay. So next slide, we're gonna just stay down there. Next slide is hip flexion. Go ahead and stand up. So with hip flexion, you wanna make sure that you're standing feet shoulder width apart, tightening your core, and you want to just bring your leg up to 90. You don't wanna activate your core, or you don't want to hyperextend or crunch your core because you're only working your hip flexor. So hands on your hip, and you're just raising up to 90 and back down, and back up, and back down. Okay? Next. Next slide. Oh, thanks. Hip adduction. So, here's the thing. So you get back on the ground, and you're going to raise up your hips. Just going on. Make sure your toes are what? Yes. Make sure you're activating what muscles? Yes, your yes, gluteus medius and your quad as well. And you raise up and down and up, back again. Good, everyone looks good, everyone looks good. We are mitigating pain and we're trying to strengthen all the muscles around the knee. Next slide, please. Next is a wall slide. Everyone can just watch, or if you have space on the wall, you want to make sure your feet are shoulder width apart and you're squatting down. There we go. Make sure you're driving through your heels and having great posture. Next slide, please. Yes, your back against the wall. So next is a reverse lunge with hip flexion. So hands on your hips, you want to lunge back, and then just like we did, you want to raise up your leg, getting that hip flexion going. So this is just activating all types of muscles. Core, your balance, and the single leg movement, as Captain Balcom said, and you're working your hip and your knee. There we go. Now everyone do it with a smile. There we go. Next is an air squat. It seems just basic, but if you do it correctly, it definitely helps with mitigating knee pain. So feet shoulder width apart, make sure your toes are pointed slightly out, and you're just squatting down and coming back up. There we go, squatting down, coming back up, driving through your heels, making sure you're activating your quad, you're gripping the ground with tripod foot, and coming back up. All right, next slide. We're not gonna do this one. But it's a box jump. It's a box jump with another jump. So she's coming and then she's jumping back up. Just making sure that she's getting her balance and then up. All right, next slide. So, in conclusion, performance strengthening exercises can help mitigate pain associated with an increased Q angle. Women with a greater Q angle of 15 degrees are predisposed to ACL tears or other patellofemoral pathologies. So if you guys want to know what your Q angle is, or if you want to just know, any more information about the Q angle, you can definitely get with your allied medical professional or your H2F team, and we'll be happy to measure your Q angle and just see what you got going on and give you some exercises. Any questions? Yes.
I know there's a lot of lower body, but what is your favorite arm exercise?
My favorite arm exercise is a combination.
You clearly work that.
Yes, I do. So I definitely love the clean and jerk. I can do that all day. I like Olympic lifts, so a lot of clean and jerks, a lot of snatches, a lot of chest flies to just isolate my shoulders, because women just have naturally just weaker up top. So I spend a lot of time just working on that, because people think, oh, I just need to do pull-ups, oh, I just need to do, just rows and things like that. But you have to do a full combination movement that actually helps, strengthen your shoulders. And that's definitely what I've done. Yes.
Okay, so specifically for myself, just speaking, I do not have hypermobility in my knees.
Okay.
However, I do notice that with the spread right carry specifically, because we are doing a lot of cutting and running back when you're doing that, are you saying that if I just work on these exercises, it'll help build my knee strength up?
Yes.
So that I do not get an injury, basically?
Yes, ma'am. These exercises will initially help, and then as you get stronger, you need to, of course, add more weight and just load more. But in learning how to plant and cut and make sure that you're using and recruiting the right muscles when you're performing these exercises will decrease your injury rate as well.
Thank you.
You're welcome. Anybody else?
For those that don't know about your H2F or know how to make an appointment with y'all, what would you advise them to reach out to?
So this is my appointment line right here that calls my government phone, and I usually make all my appointments for my H2F, for sustainment in H2F. So 785-307-5933 rings right to my government phone, and this is my email, that's the wrong email, but this is my email as well. And I usually just take people from there, and if you have any questions, I'm definitely a facilitator, so if I can't help you, I'll get you to team members people on my team to help with that question or anything else you need going on.
we do have a H2F contact slide for each of the different brigades at the very end, so that way you can know which team to contact. However, like Kim said, if you contact the wrong team because you might be on a different or in a different brigade, we will help facilitate making sure that you get to the right entity.
Is any more questions? Thank you.
Everybody stand, hands on our hips, kind of in this Superman position. We're gonna take 10 deep belly breaths, really expanding our diaphragm, and then forcefully exhale out. You guys wanna close your eyes, go for it. Big deep breath in, and I wanna hear that exhale. Whenever you guys finish with that, you guys can sit back down. How you guys feel after that? A little relaxed? I love throwing that in there. I used to have an old professor that would make us do that before class. The research behind that is really awesome. We see decreased cortisol levels, which is stress, and increased testosterone. So anytime you're feeling nervous, anything like that, you need to calm down. Really great exercise. My name is Corynn Miner. You can call me Coach Miner or Corynn. It doesn't really matter to me. I'm the strength and conditioning coach for 1st Brigade. I've been here a little over 2 months now. I was born and raised Tampa, Florida. I got my bachelor's, Florida? Yes, let's go. Yeah, so I got my bachelor's and my master's in the University of Tampa, where I also played 6 years of collegiate softball. So, yeah, COVID gave me those years back. So yeah, I've been in this field for a little bit, and today I want to talk to you about strength differences. So I want to debunk a couple of myths first, right? Who here has heard we shouldn't lift heavy, or women shouldn't lift heavy because they're bulky? Or someone's told you that? Yeah, absolutely. So becoming stronger does not automatically mean you're going to get big and bulky, right? Unless you're eating at the volume of an elite bodybuilder or training at the volume of an elite bodybuilder, it's not going to happen. Okay, it's very intentional. I used to always have a lot of female athletes come up to me and be like, "Hey, Corynn, I'm afraid to push myself. I don't want to get bulky." I'm like, "All right, well, I know what your training looks like, so I'm putting you through it. Tell me what your diet looks like." And they would tell me, I'm like, "You're okay, no problems here." So I don't want you to feel that way whatsoever. Research shows that training with heavier weights can help you lose weight, and it can also increase our bone mineral density, which we've already spoke a little bit about. We know that as we become older, we're more susceptible to osteoporosis, and load-bearing movements are really beneficial in helping combat that. To lose weight, you need to do lots of cardio. Who here has maybe believed that or has been told that a little bit? Yeah, right? So unless you love running and just want to go out and do that every day, good for you. That's not me, personally. But you do not need to do excessive amounts of cardio if this is your goal to lose weight, right? Muscle is expensive, and what I mean by that is you're going to burn calories if you have more muscle mass on your body. So don't feel like I need to go and do tons of cardio because I need to reach my goal. Strength training can help you in that process as well. So some benefits: resistance training is an essential component of any program. So running is awesome, but you can also, in conjunction, resistance train as well. Our main goal when we resistance train is to increase our health and fitness levels and decrease injury rate. Pretty straightforward, right? As simple as it gets. Studies indicate that women are capable of tolerating and adapting to the stresses of resistance exercise, and the benefits we see from that are substantial. We've talked about those benefits a little bit. Decreasing stress levels overall, increasing our cognitive health, it's endless, the advantages. So some strength differences. Women have about 2/3 the strength of absolute strength compared to men, and our lower body strength is closer compared to upper body. And a lot of that is due to our physiological makeup. We tend to have less fat-free mass on our upper body, right? I had a soldier last week come up to me and he was like, man, I'm pissed. My wife can do a pistol squat and I can't. Like, I'm sorry, buddy, but awesome for her. So just as an example of that. When we're talking about strength and it's expressed relative to muscle cross-section area, all that means is like we take a muscle fiber, we cross-section it. So just measuring how big that muscle fiber is, there is no significant difference between genders. Meaning, muscle quality is not sex-specific. So, muscle's not going to say, hey, you're a man, I'm going to put more muscle on you. No, right? It doesn't matter, as long as the training variables are there, we're going to build muscle just as easily as men could, considering all our other recovery and diets are dialed in. So, with the quality resistance training program, women can increase strength at the same rate as men or faster. Absolute strength gains are greater in men, but relative strength increases are the same or greater in men. Absolute strength is just the total amount of weight lifted in a session. Relative strength is your individual lifting capacity, so like pound for pound body weight. So when I talked about those pistol squats, that makes sense, right? We're thinking more maybe body weight movements, pistol squats, push-ups, inverted rows, exercises like that. Also, research has shown that women can tolerate more volume, lower body. We can adapt and recover quicker compared to men, which is awesome. Regardless of the muscle groups involved, your performance, job, competition, whatever you're training for, a program is meant to improve that, right? So like, regardless of your sex or gender, muscle is not biased. Does that make sense to everybody? Kind of? Okay. Can you go back 1 second, please? Notice how I put differences in quotation marks, right? Because there are physiological differences, but again, we can build muscle at the same rate as men, or even greater. Okay, we'll go next. So I know we talked about ACL briefly. I just kind of wanted to bring awareness to people. We are 6 times more likely to incur an ACL injury, and there's so many causative factors. They spoke on a few of them. Joint laxity, or just how your physiological makeup can be a part of it too, but a really big significant factor is neuromuscular deficiency, meaning just like muscle weakness. Our neuromuscular connections with our muscles or tendons or ligaments, they're not strong enough to be able to withstand these outside forces, right? So this can lead to abnormal biomechanics. So, have you ever seen somebody squat or like land from a box jump and we have this knee valgus? Yeah, not fun. So that's what that can lead to. Most of these injuries occur from non-contact mechanisms, so like planting or pivoting. Anybody play soccer? Have you ever seen somebody have a knee injury or a curb one? Did it happen when they were planting? Or, yeah. I've seen a softball player field the ground ball, take a step, boom, down, right? A lot of these happen from these non-contact mechanisms. So learning how to decelerate properly, landing mechanics are super important. Say if we're jumping off a box jump and then into that vertical jump like we saw that example, landing mechanics for that are super important. The next one. And then how can we combat that and enhance our knee strength? They threw out a lot of great exercises. Any one of those are awesome. We just want to focus on increasing strength within your core, glutes, quads, hamstrings. Just specific for that ACL, overall, we want to train full body. So any squats, Nordic curls. Can anybody in here do a full Nordic curl? If you can, props to you, because it's really hard. Also, research has shown that those are really good for helping prevent ACL injuries, so I would recommend throwing that into your program if you can. Lunges, we talked about how single leg exercises are really important, joint stability, things like that. RDLs and TKEs. If you've had a knee injury, you're probably going to do TKEs till the day you die, because they're super important. And then increasing that neuromuscular control of the knee joint, so doing plyometrics, doing box jumps, having really good single leg balance, having those good solid landing mechanics. But overall, having a well-rounded training program is super effective, right? I think we've all kind of understand that point. Just the most important factors, enjoy what you do. If you pick something that's super hard and hard to progress from, the sustainability is not going to be there, right? So finding activities that you enjoy and we understand the benefits from it, you're going to reap awesome things from that. Does that make sense? Do we have any questions? Terminal knee extensions. So normally, like let's say I have a rack in front of me, we wrap a band around the rack. The band's going to go around the back of your knee, and then we're fully extending, so getting that quad contraction here. Those are really good for preventative injuries anyway. I would throw them in as a warm-up, or honestly, whenever in the workout. Any other questions?
How would that translate to like when you lead PT and like most of the time you only get male soldiers, but like let's say there's a female soldier, right? And how would that like I guess impact it or make it like better for both genders?
You mean like the exercises you're programming?
Mm-hmm. Yes.
There's-
Like, what are we supposed to be aware of, basically?
So if anything, like if I had to point something out, it would be specifically structures around the knee. But like I was saying earlier, we don't need to like throw in exercises that are specific for women. There's not going to be a book saying, hey, these exercises are only good for males and females. It's not like that. You don't need to change your program. If anything, now that you're aware of this, you can add these exercises in there, but they're going to be beneficial for both genders and just overall. Does that help? Okay. Any other questions? You good? Okay. Thank you.
Alright, good morning everybody. My name is Captain Godin. I'm the Chief of Physical Therapy here at IAC, and I'm also the pelvic floor therapist here at IAC. Has any Alright, good morning everybody. My name is Captain Godin. I'm the Chief of Physical Therapy here at IAC, and I'm also the pelvic floor therapist here at IAC. Has any of you guys, do you guys know what pelvic floor therapy is? Raise your hand if you've done it. Or cool. Okay, cool. So it's a pretty small field. I'm the only one here that does pelvic floor therapy right now. We do have other providers trained, but as far as seeing patients, I'm the only pelvic floor therapist. And then we have 2 providers off post that we refer to. Unfortunately, I'm PCSing, so right now we're referring off post, but we have really great providers in the network that we can kind of make sure you're being seen for that. So I'm just going to be going over pelvic floor therapy and kind of what that is. And then I'm going to be going over the pelvic floor anatomy and also the muscles within your hip that helps support that as well, just so you have a picture, because we all kind of forget that there are muscles down there. And so just so that you can kind of see that. And then I'm going to go over the prevalence of pelvic floor dysfunction and how common that is. And then I'm really going to talk about pelvic floor primarily postpartum and getting back into returning to duty, returning to running, returning to weightlifting, what that looks like and what you should keep in mind. And then we'll go over just some pelvic floor exercises and how I program and give certain patients different exercises and what exercises you should be working on just to help improve the health of your pelvic floor. So pelvic floor physical therapy is the evaluation and treatment of your pelvic floor muscles. And so the way it looks like if you're going to come see a pelvic floor therapist is we usually look at your hip and your back because that plays a huge role. And then we look at functional things because we don't all live in like this seated lying down position. So we look at your squatting, your single leg strength, which is super important. We also look at any lunging or anything that you have issues with. So if you're like, I have a lot of pelvic pain or if you have a lot of leakage with squatting, I'll look at that and make sure there's nothing you need to like change or tweak with that. And then we do an internal exam. This looks very different than a pap smear. So I don't use a speculum and I'm just pressing onto your pelvic floor muscles. I feel like it's a little more comfortable than a pap smear, but I'm feeling for if you have any tension, if you have any laxity, and then also if you have good pelvic floor strength and relaxation. So we kind of look at all of that all together. And if you're not comfortable doing an internal exam, don't feel like you have to do an internal exam when you show up to our pelvic floor therapist. You always have the right to ask for a chaperone or to be like, today's not the day, and that's perfectly fine. So just how do you become a pelvic floor therapist? If not all physical therapists are pelvic floor therapists, you have to do kind of extra training to do it. And as a pelvic floor therapist, there's kind of tiers of training. So I'm level 1 trained. I primarily can work on female anatomy, and then the next level is male anatomy. So there is pelvic floor therapy for males, but I'm not trained in that. The providers off post are trained in that. And so if any males have pelvic floor dysfunctions as well, we can also see that. And then we treat primarily urinary incontinence. So if you have any urge incontinence, this is when you can't hold it to make it to the bathroom, and you have a quick urge and you can't hold that. You have to treat stress incontinence. So that's when you have, like when you laugh, sneeze, cough, you squat, and you have stress incontinence, and you pee yourself with that. And then there's mixed incontinence, which you can have both of those symptoms at the same time. That's fairly common. And then also pelvic pain. So if you have pubic pain or SI joint pain, which are the two joints in the back where your sacrum connects to your pelvic bones or to your hip bones, and then any prolapse. So this is very common after pregnancy, but you can also have prolapse if you have never been pregnant before. And that's just a collapse of either your uterus, your bladder, or your rectum, and that's collapsing onto the vaginal wall and causing bulging and heaviness. So that's something we treat or we work on managing. And then dyspareunia is just the fancy word for saying if you have pain with sex or vaginal insertion. And then diastasis rectus is the separation of your core muscles that can occur during pregnancy or after pregnancy. And it's common, it needs to happen when you're pregnant, but sometimes people just need some training to kind of work on getting that back together. And then I also just, if you have back pain or hip pain during pregnancy or after pregnancy, which is very common, I also treat that as well. Next slide, please. So just going over the pelvic floor anatomy here, you have really 3 levels of your pelvic floor. We kind of split it up into 2. So you have your superficial muscles here. Those are that first layer. And then you have your deeper muscles. Your first layer muscles are just there to kind of close around your urethra or around your vagina, just to kind of keep everything in. Your deeper muscles create a bowl and help support everything. And so a lot of times people can have discrepancies there. They can have really strong superficial muscles, or those superficial muscles are really, really tight, but then their deeper muscles are weak and not activating. And so this is just a good picture of what your pelvic floor muscles look like. And then next, I'm going to go over just some hip muscles that play a huge role in supporting your pelvic floor. So next slide, please. Sorry, I got ahead of myself. With the next thing we're going to go over is just some core muscles. So your core, I like to tell people that your core is like a canister. Okay, so if you think about like a soda can, the top of your soda can is your diaphragm, the bottom is your pelvic floor, and then around that is your core muscles. You have 3 levels of your core muscles. You have your 6-pack abs, which are your rectus abdominis. If you were to take that off, then you have your obliques, and then you have your transverse abdominis, which is pretty much your corsate. And so when you inhale, your diaphragm pulls down and it relaxes your pelvic floor. And then when you exhale, the opposite occurs. And so I use a lot of diaphragmatic breathing. So that was a good exercise, Corynn, to just help relax or strengthen the pelvic floor, because it naturally occurs when you're breathing. Next slide, please. Other muscles that help really support your pelvic floor are your hip muscles, and I work on this a lot. So if you see me as a PT, we're working on your hips and core. We don't do much Kegels, to be honest. It's all hip and core. So these muscles here, you have your rotators. So those help support your pelvic floor. And then you also have your glutes, which help keep your hips leveled in a single leg stance. So I'm gonna have everyone stand up. So I want you to just balance on, you can put hands on your hips too. Just balance on one leg and see what that other side does. Does it hike up? Does it drop down? Does it stay nice and level? And so you can relax. So the muscle that helps create that stability across your hips is your glute med and also some of your glute max, but that keeps everything nice and stable. You guys can go ahead and sit down. But it also helps create stability within your pelvic floor as well, because if you don't have really, really strong hips, your pelvic floor will either be weak also, or it will get tight, and it will compensate for that. So we work on that as well. And then another huge muscle that we work on that's also a rotator is your obturator internus here. This is a picture of kind of pressing on that muscle vaginally. And so that muscle creates the wall of your pelvic floor, and we end up, because it's an external rotator, and a lot of people have weakness in the external rotators, there's a lot of tightness there. And when you have tightness there, it can refer to like your abdomen or into your pelvic floor or posteriorly, like kind of near your rectum, and it can cause some pain with that. So that's another muscle we work on in pelvic floor as well. Next slide. And then another huge muscle and that I see a lot, causes a lot of tightness and pain, are your adductors. So your adductors are the muscles in your groin, and they attach here onto your pubic bone here. And so it's I see this a lot, like postpartum and during pregnancy, when you're growing and you're making room for your baby, your pelvic floor is just on stretch. And the only thing to kind of keep that joint together is, or not together, that's a bad word, to just keep it stable is those adductors, and they tend to get really, really tight, really weak, and really irritable. And so we work on that, strengthening that, and also stretching that. So you can stretch a muscle all you want, but if you don't work on strengthening that, it's not gonna meet the demand of what you ask it to do when you go back and after you have your baby and you end up going back to running. So stretching is important, but strengthening is also something that you also need to work on. Next slide. So pelvic floor dysfunction is very common. So there was a study done in 1999, and about greater than 30% of female soldiers report some type of urinary incontinence. And this was in people who had babies and who haven't had babies before. And I think I equate this to a lot of times, like when we're in the field, no one wants to like pee in the porta potty, so we all hold it, and that just kind of messes with how you regulate your bladder. And then about 42% of female athletes without history of pregnancy has reported urinary incontinence at some point. So it's even common in that female athlete population. 1 in 6 women have chronic pelvic pain, and about 95% of females with low back pain end up having pelvic floor dysfunction and don't even know it. And so you can kind of see, like, this is definitely things that we just don't know. Like, we all think it's normal. What I tell patients is, like, it's incontinence or like dyspareunia or pain with sex. It's not normal, it's just common. So because it's so common, we're just like, oh yeah, that's what happens after I have 6 kids. But there's definitely things that we can do to really help support you and to make sure you're doing the right exercise and help manage that. Next slide. So now I'm going to go into kind of returning to duty and returning to weightlifting and running. So I feel like that's a big thing people ask me is like, man, I'm about to have a baby, or I've just had my baby. What's kind of the guideline, or what do I need to follow after I have that to get back to doing your job and doing the physical things we need to do in the Army? So there isn't really much research specifically to the military population with pelvic floor dysfunction. Most of the research that we have is on returning to running and returning to weightlifting, so we can kind of build upon that. But our field is still in our infancy, so we still are we're waiting for that like good research, and so we only have expert opinion or just retrospective studies where they look back in time to kind of see how people respond. So things may change over the years, which is good, and I'm hoping that our field will grow and we'll end up having more research, but right now we just have expert opinion to kind of build our practice. So with getting back into running, the biggest thing with pelvic floor and postpartum is that running is a high impact activity. So a lot of times we think, oh yeah, I've ran before. I'm just gonna go back and run when my OB clears me at 6 weeks. That's not the right thing to do. So we need to work on a lot of hip stability, core stability, pelvic floor endurance. So it's different if you can do a strong Kegel, that's different than versus holding that Kegel or holding that contraction for a 2-mile run. So we need to make sure that's solid. Right now, there's not a current guideline for returning to running after pregnancy. The only thing we have here is the self-published guideline that this group put out. The reason why they self-published it is because they wanted it to get out quickly. The publishing process to get research out just takes forever, so they're like, people need to know this, so we're just gonna throw it out there. And so they give out guidelines that I'm gonna go over just to keep in mind for returning back into running postpartum. So the biggest thing that they recommended is doing a individual pelvic floor assessment and rehab. So it is not, you have the right to ask your OB, like, hey, I want to do pelvic floor therapy, you can put a referral in just to like clear you. And that's perfectly fine to ask. And again, that referral would go through, and we have great providers off post at Mathis and Good Life PT that can help you on that journey of getting back into running postpartum. The other thing is we should wait until 3 months postpartum at minimum to get back to running. And that doesn't mean you can't do any impact. So before that, you should be doing walking, you should be doing a lot of strength training within your tolerance. You should be doing some like light plyometrics, but we don't want to be going back into that run that you did before you had your baby. We need to work on making sure that you don't have any incontinence, that you don't have any pelvic pain, that you have good single leg strength. So that's a huge thing, is you may have a solid single leg squat with good knee and hip alignment on one side, but the other side is just lagging, and that's just something you need to work on. And we also need to make sure you have good hip stability when you're in that single leg position. And then we also need to make sure you have good load management techniques. So when you're running and when you're lifting, you're not just bearing down. And then you have good proper running form, if that's something that you need to work on. And then that you also have good strength. And then other things you gotta keep in mind after you have your baby and get back into running is there's definitely weight changes, so that may also affect that. Your breathing, so when you have your babies, you end up having like your ribs distend a little bit to make room for your baby. And I don't know who's had a baby before here. Yeah. Have you ever like after you give birth and you like try to take a deep breath in and you're like, I don't know why, I can't breathe today. Yeah, that's real. And that's just because your diaphragm and your ribs flare out, and so your diaphragm's just a little stretched or it can get tight, and so it can cause just breathing differences, and so diaphragmatic breathing is a good thing we do to just kind of help relearn how to use that. And then the other thing we need to keep in mind is if you're lactating or you're pumping, you need to have good nutrition to help support that. And just making sure that you have good recovery with sleep, because we all know after a baby you don't get much sleep. Everyone thinks we're on vacation, but you're not. So the biggest thing is you keep that in mind and keep that in mind when you're training. All right, next slide, please. So there's now new research on pelvic floor and postpartum getting back into weight training. So it's fine to weight train after you have your baby. I would still wait until that 6 week postpartum time, or 6 weeks postpartum visit with your OB. That doesn't mean you can't do anything. You can still walk, but don't do any like heavy lifting. Especially if you have a C-section too, that just looks a little different because you have they come through all those core muscles, so we should make sure those heal well. But it is safe to get back into weightlifting and weight training after pregnancy. But these are high impact exercises. So common things I see is people have poor intra-abdominal pressure management. And so when you're lifting, a lot of times what I see is people either excessively bear down, or they just kind of bear down into their diastasis or down into the pelvic floor, and that can cause leakage. So we just have to work on things to help manage that, or just help you control that. Because awareness is like half the battle. If you're aware of it, you can learn how to address it. You tend to have like core weakness and hip stability problems after you have your baby, so just making sure that you're isolating things and you're doing proper form when you're weight training. And then you can also have pelvic floor tightness and adductor tightness. I see that a lot more common than incontinence, and that's just because I'm in a younger population, and so a lot of times we tend to have tight and overactive pelvic floors, and your pelvic floor just gets really, really tight as you lift, and so we need to work on relaxing that. And so those are the things we work on in pelvic floor therapy to kind of help you get back into weightlifting if that's a goal you want to do. And it's, we got to do that in the Army, so it's something that we need to make sure you're getting back to doing safely, and we're supporting you doing that. All right, next slide. And then the other thing that's really coming out is it safe to weight train during pregnancy? Does anyone have an answer for me?
Yes.
Yes. Very good. Yeah, so it is good to weight train during pregnancy. The biggest thing is just to make sure that it's not the time to go PR on your snatch. And if you're really pregnant, don't clean a bunch of weight because you could hit your belly. But the biggest thing is making sure that you're doing your form properly. Within that first trimester, you pretty much can do whatever you feel like it. I know sometimes you have nausea and that plays a huge role, but you can do most of your exercises. It's not until that second trimester and third trimester where you have to modify things just to make room for your belly. So your squat's gonna look different. You're not gonna be squatting nice and narrow. You're probably gonna have to be a little wider, and you might also just have to modify the weight. Another thing is you might be able to do lunges 1 week, and then the next week you're like, lunges really hurt my pubic bone. And so we just have to manage things, or we're just like, okay, well, maybe we just don't do full lunges, let's just do mini lunges. And so if the P3T team can kind of help you modify that, but for the most part, it is safe to weight train, and it's honestly, I think it's an important thing to do because you have to do a lot of awkward things after you have your baby. You're gonna have to be bending over a lot, and it's not gonna be a pretty nice deadlift. It's gonna be you're tired and you're reaching over to get your baby. And so you need to be really strong postpartum, and that will also help your recovery getting back into things during your postpartum time. All right, next slide. So the things I really focus on in pelvic floor therapy is I really try to identify if a patient has pelvic floor weakness or pelvic floor tightness. And you can also have a mix of both. So don't feel like you have to be in one group and they're like, oh, I have incontinence, so I must be tight. You can also be weak as well, but that's kind of the two big camps that I try to figure out if a patient's in. And so with pelvic floor weakness, we're working on a lot of core stability because when we contract our deep core muscle, that's also called our transverse abdominis or our TVA, research shows that helps also contract our pelvic floor muscles. And then we work on a lot of hip stability. And then we work on pelvic floor contraction. And a lot of times people are like, well, if I have incontinence, I should just do Kegels all the time. But that's not necessarily always the right answer. You could have you could have a really strong Kegel, but you may not be able to hold it. So there's different types of Kegels we work on. We work on either a strong hard Kegel or a quick contraction or a hold. Because sometimes people don't end up having leakage until they're 2 miles into their run, and that tells me, okay, it's more of an endurance issue than it is truly a strength issue. And then for pelvic floor tightness, I work on a lot of adductor stretching, a lot of hip flexor stretching. I do a lot of cat-cows where we're moving the pelvis, and that also helps open up the pelvic outlet to help stretch those pelvic floor muscles. And I do a lot of breathing exercises. So if you go see a pelvic floor therapist and they make you do deep breathing, just know that is, if you don't understand the why, the biggest reason why is because when you pull down that diaphragm, that pelvic floor also relaxes and opens up as well. So that's all I have for today. Does anyone have any questions on pelvic floor therapy? Cool. All right. I'll hand it off to Captain Eberlein.
Losing weight? Gaining weight? Anybody else?
What's part of weight loss?
The Army forced you to? That happened? Yeah? Alright, anything else anyone wants to share? Yeah? Gestational diabetes? Those are a lot of great examples. So as a dietitian, we see quite a variety of soldiers, quite a variety of patients the most common one people think of is weight loss, because they think they're gonna come in and we're gonna say, yeah, eat more carrots and stop eating all the cupcakes. Not generally where we go, but it's a pretty common thought to have. But we do see a lot of weight gain in soldiers, especially female soldiers who want to put on muscle. We see pregnancy, for pregnancy nutrition, any medical condition, high blood pressure, high cholesterol, and then also performance. So I know we've talked a lot about injury prevention. We haven't focused a lot on how to maybe perform in that excelling area. But if you want to perform, if you want to put on muscle, you have to eat right. You have to eat the right things. That's really important. So that's something that we talk about a lot in the nutrition field as well. Today we're talking about none of those things. We're talking about a couple different topics, but the first one is going to be the female athlete triad, or REDS, which stands for Relative Energy Deficiency in Sports. Has anybody heard of these before? Okay, a few people. Okay, go to the next slide. So there's a lot of big words on this slide. The female athlete triad is actually a clinical definition. We used to think that it was a phenomenon only specific to females. We're seeing now that it's actually in the male population, so we've renamed it REDS, because then it's not specific to one gender. So bear with me through this science really quickly, but the first step in the female athlete triad is insufficient energy availability. And I'll go over more of what that means, but essentially it means you're not eating enough calories, which is very, very common in a military setting, and very common especially in a female military setting. So that low energy, that lack of calories, leads to this thing called the hypothalamic pituitary ovarian pathway being disrupted. What that means is the connection between your hypothalamus, your pituitary gland, and your ovaries. They have a connection, and that connection has been disrupted because of your lack of calories. That pathway being disrupted leads to altered luteinizing hormone. Anyone ever heard of luteinizing hormone before? Think back to your anatomy, physiology, maybe learning about the menstrual cycle in health class. Luteinizing hormone and follicle stimulating hormone are two hormones that regulate our menstrual cycle. They both raise before ovulation in the menstrual cycle, and so they're really important to regulating our menstrual cycle throughout the month. Well, when that luteinizing hormone is altered, we have two things happen. One, our normal menstrual function there's a disorder there. Right? Maybe our periods change, maybe they go away entirely. I'll talk about all these things. The second one is we have this thing called O-estrogen, and it decreases. And that decrease leads to bone mineral loss. So our three boxes highlighted in red: insufficient energy availability, bone mineral loss, and normal menstrual function being dysregulated. Those are the three things that make up the triad. And I'll go over each of those a little more. Next slide. So, you can click one more time. So, energy availability. There's a lot of math on this slide. Dietitians, we do a lot of math in the daily, so I couldn't do without doing the math. But energy availability is actually a relationship between how many calories you're intaking related to the exercise that you're doing and how much fat-free mass you have. So fat-free mass is essentially anything in your body that's not fat. Bone, muscles, tissues, your organs. All of those things require calories to function normally. So energy availability is about feeding the fat-free mass appropriately to have enough energy to do normal activities. So with my equations, bear with me with some math. Say you have a 165-pound female. We do everything in kilograms, technically in the medical world, so we convert that to 75 kilograms. Say that person has 30% body fat, just an average or an estimation. Do some math, we determine that person has 52.5 kilograms of fat-free mass. We multiply that by 30, right? 30 calories per kilogram, and we get around 1,575 calories a day for safe living. How many of you in this room have heard of eating 1,200 calories a day to lose weight? Or been told you need to eat less than 1,500 calories a day to lose weight? Right, exactly. A lot of hands were just raised. That 1,575 is for safety. That's not ideal. That's like the minimum I'd want somebody to be at. So in general, the female population is told to eat fewer calories because they want to lose weight, because they want to lean out. But if you want to perform, if you want to put on muscle, if you want to have athletic abilities, we have to eat to sustain those activities. So decreased energy availability leads to a couple things. Decreased lean body mass and decreased muscle performance. That one's kind of a given, right? If we can't feed our muscles, we can't gain new muscles, we can't maintain those muscles. It impairs our endocrine function, So that decreased luteinizing hormone, decreased T3, which is thyroid hormone, decreased IGF, decreased leptin, which is a hunger hormone, decreased insulin. So all those things are impacted by having less calorie intake. And then also this leads to this high bone turnover, which we're going to talk about next. Next slide. So the two things on our triad, mental changes in bone mineral density. We're going to go to the right first, because I just mentioned bones. But bone mineral density, that's coming from that lack of calories, just means we're leading towards osteoporosis, which we kind of talked about already. The thing about osteoporosis, it's really hard to diagnose because we need to do bone scans, or we need to do a DEXA, so there's more advanced technology involved in that. The presence of stress fractures is generally one of our diagnostic criteria. If you're a female, we talked about how prevalent stress fractures are. A study done in recruits showed that 5% of male recruits had stress fractures versus 21% of females. So stress fractures much higher in the female population. So technically looking at T-scores, we look at bone mineral loss, but again, we need more advanced technology to basically assess that number. So that stress fracture presence is a good indication. And then lastly, we have menstrual changes. So this one gets kind of complicated when you add in things like birth control, because it kind of messes with our normal cycle. But normal menstruation is on average, 24 to 34 days of a cycle. If you are not within that window, but that's normal for you, know you're normal, right? If you are 28 days on the dot every single month, and you change from that 28 days, that's a change. But if you're somebody who's every 30 days, that's normal for you. So knowing your normal is really important to assessing if this ever changes. There's oligomenorrhea, which is cycles that are greater than 35 days. That can indicate a little disruption in your cycle. And then there's amenorrhea, cycles that are greater than 90 days. Losing weight? Gaining weight? Anybody else?
What's part of weight loss?
The Army forced you to? That happens? Yeah? Alright, anything else anyone wants to share? Yeah? Gestational diabetes? Those are a lot of great examples. So as a dietitian, we see quite a variety of soldiers, quite a variety of patients. The most common one people think of is weight loss, because they think they're going to come in and we're going to say, yeah, eat more carrots and stop eating all the cupcakes. Not generally where we go, but it's a pretty common thought to have. But we do see a lot of weight gain in soldiers, especially female soldiers who want to put on muscle. We see pregnancy for pregnancy nutrition, any medical condition, high blood pressure, high cholesterol, and then also performance. So I know we've talked a lot about injury prevention. We haven't focused a lot on how to maybe perform in that excelling area. But if you want to perform, if you want to put on muscle, you have to eat right. You have to eat the right things. That's really important. So that's something that we talk about a lot in the nutrition field as well. Today we're talking about none of those things. We're talking about a couple different topics, but the first one is going to be the female athlete triad, or REDS, which stands for Relative Energy Deficiency in Sports. Has anybody heard of these before? Okay, a few people. Okay, go to the next slide. So there's a lot of big words on this slide. The female athlete triad is actually a clinical definition. We used to think that it was a phenomenon only specific to females. We're seeing now that it's actually in the male population, so we've renamed it REDS, because then it's not specific to one gender. So bear with me through this science really quickly, but the first step in the female athlete triad is insufficient energy availability. And I'll go over more of what that means, but essentially it means you're not eating enough calories, which is very, very common in a military setting and very common especially in the female military setting. So that low energy, that lack of calories, leads to this thing called the hypothalamic pituitary ovarian pathway being disrupted. What that means is the connection between your hypothalamus, your pituitary gland, and your ovaries. They have a connection, and that connection has been disrupted because of your lack of calories. That pathway being disrupted leads to altered luteinizing hormone. Anyone ever heard of luteinizing hormone before? Think back to your anatomy, physiology, maybe learning about the menstrual cycle in health class. Luteinizing hormone and follicle stimulating hormone are two hormones that regulate our menstrual cycle. They both raise before ovulation in the menstrual cycle, and so they're really important to regulating our menstrual cycle throughout the month. Well, when that luteinizing hormone is altered, we have two things happen. One, our normal menstrual function is there's a disorder there. Right? Maybe our periods change, maybe they go away entirely, and I'll talk about all these things. The second one is we have this thing called oestrogen, and it decreases. And that decrease leads to bone mineral loss. So our three boxes highlighted in red: insufficient energy availability, bone mineral loss, and normal menstrual function being dysregulated. Those are the three things that make up the triad. And I'll go over each of those a little more. Next slide. So, you can click one more time. So, energy availability. There's a lot of math on this slide. Dietitians, we do a lot of math in the daily, so I couldn't do without doing the math. But energy availability is actually a relationship between how many calories you're intaking related to the exercise that you're doing and how much fat-free mass you have. So fat-free mass is essentially anything in your body that's not fat. Bone, muscles, tissues, your organs, all of those things require calories to function normally. So energy availability is about feeding the fat-free mass appropriately to have enough energy to do normal activities. So with my equation, bear with me with some math. Say you have a 165-pound female. We do everything in kilograms, technically in the medical world, so we convert that to 75 kilograms. Say that person has 30% body fat, just an average or an estimation. Do some math, we determine that person has 52.5 kilograms of fat-free mass. We multiply that by 30, right? 30 calories per kilogram, and we get around 1,575 calories a day for safe living. How many of you in this room have heard of eating 1,200 calories a day to lose weight? Or been told you need to eat less than 1,500 calories a day to lose weight? Right, exactly. A lot of hands were just raised. That 1,575 is for safety. That's not ideal. That's like the minimum I'd want somebody to be at. So in general, the female population is told to eat fewer calories because they want to lose weight, because they want to lean out. But if you want to perform, if you want to put on muscle, if you want to have athletic abilities, we have to eat to sustain those activities. So, decreased energy availability leads to a couple things. Decreased lean body mass and decreased muscle performance. That one's kind of a given, right? If we can't feed our muscles, we can't gain new muscles, we can't maintain those muscles. It impairs our endocrine function, So that decreased luteinizing hormone, decreased T3, which is thyroid hormone, decreased IGF, decreased leptin, which is a hunger hormone, decreased insulin. So all those things are impacted by having less calorie intake. And then also this leads to this high bone turnover, which we're going to talk about next. Next slide. So the two things on our triad, mental changes in bone mineral density. We're going to go to the right first, because I just mentioned bones. But bone mineral density, that's coming from that lack of calories, just means we're leading towards osteoporosis, which we kind of talked about already. The thing about osteoporosis is it's really hard to diagnose because we need to do bone scans or we need to do a DEXA, so there's more advanced technology involved in that. The presence of stress fractures is generally one of our diagnostic criteria. If you're a female, we talked about how prevalent stress fractures are. A study done in recruits showed that 5% of male recruits had stress fractures versus 21% of females. So stress fractures much higher in the female population. So technically looking at T-scores, we look at bone mineral loss, but again, we need more advanced technology to basically assess that number. So that stress fracture presence is a good indication. And then lastly, we have menstrual changes. So this one gets kind of complicated when you add in things like birth control, because it kind of messes with our normal cycle. But normal menstruation is on average, again on average, 24 to 34 days of a cycle. If you are not within that window, but that's normal for you, know you're normal, right? If you are 28 days on the dot every single month, and you change from that 28 days, that's a change. But if you're somebody who's every 30 days, that's normal for you. So knowing your normal is really important to assessing if this ever changes. There's oligomenorrhea, which is cycles that are greater than 35 days. That can indicate a little disruption in your cycle. And then there's amenorrhea, cycles that are greater than 90 days. And that's, by definition, an absence of a menstrual cycle. This does not account for changes due to birth control. So a lot of people who are on birth control, especially IUDs, don't have periods at all. So it's a really hard thing to assess when you take out one piece of the triad. So that means that you must tune more into bone mineral density, right? Strengthening those muscles, watching out for stress fractures, injuries, and accounting for that energy intake. Because you're taking a piece out that you can look for, that you can manage. Okay, next slide. Okay, we're kind of changing topics a little bit, but this relates. We're going to talk about the most important nutrient considerations for women's health. When I have soldiers come into my office and they're, tell me about their diet, tell me what they eat, these are things I look for the most because they're the most clinically indicated as important for a female. Next slide. First one being iron. This one, I think for obvious reasons, is important for females because we lose blood every month, right? We have a period, you lose blood. That's pretty good cause and effect right there. But iron's also important for our bone health. It's a mineral in our bones. It helps synthesize collagen. So this is also important for maintaining bone mineral density. So why it matters? We lose blood more frequently, so we need to replace it. We need to improve our blood oxygenation with increasing our iron intake. Our iron needs are 18 milligrams a day compared to a male at 8 milligrams a day. That's double the male needs for a female. Most females are not intaking enough iron because a lot of females don't eat a lot of meat. And that's just a generalization. It's not applied to everybody, but based on soldiers that I've seen, a lot of females don't eat iron-containing foods. So how do we do this more? We eat more red meat, or seafood, fortified cereals, spinach. Those are all examples of iron-containing foods. The more we consume those in our diet, the more iron we consume, the less risk we have of a deficiency. Anyone ever heard of anemia before? Been diagnosed with anemia? Anemia is from lack of iron in our diet, or lack of iron overall. A lot of people who have really, really heavy periods, that are really heavy for maybe a couple of days even, they struggle with anemia because they're losing more blood than they can basically replace, and they don't have enough iron to account for that. When you're pregnant, your needs go even higher, 27 milligrams per day. You know why? You're doubling your blood volume. You are creating another human being. You have to add more blood. Your blood is expanding rapidly throughout your 9 months of being pregnant. Your needs go up, which is why they often prescribe iron supplements when you're pregnant or in your prenatal vitamins. Next slide. This was mentioned earlier, so calcium and vitamin D, really, really, really important for bone health. So calcium is the most abundant mineral in bone, and it helps maintain that bone mineral density, which we know prevents stress fractures. Vitamin D regulates our calcium metabolism, which is why you often see them supplemented together, prescribed together, maybe they're in foods together. So our sources, our big one is going to be dairy products. That's why we always hear as kids like 3 glasses of milk a day for calcium, for strong bones. Well, there's some truth in that, right? Dairy products are a main source of calcium, but any alternative dairy source as well. So if you're lactose intolerant, you don't want to consume dairy, almond milk, oat milk, cashew milk, whatever new milk they have out tomorrow. Those are generally fortified with calcium because they want to replace milk in the diet. Also kale, almonds, spinach, collard greens. Honestly, if you ever eat a dark leafy green, you're probably in the right place. They have everything you need in them. Our needs are the same as males, right? 1,000 milligrams per day of calcium and 600 IU per day of vitamin D. It's the same for males, but as you get over the age of 50, for a female, your needs go up to 1,300 milligrams and 800 IUs of vitamin D because of that increased risk of stress fractures and osteoporosis. So, even though they're the same needs, we acknowledge that your needs increase when you're over 50 because your risk goes up. For reference, they used to recommend 3 glasses of milk a day because 1 glass of milk, 1 true glass, so 8 ounces of milk, has about 300 milligrams of calcium in it. So 3 glasses a day would get you to 1,000 milligrams-ish. That's how that recommendation took place. Okay, next slide. Okay, so my next topic is disordered eating and body image. I'm kind of rapidly changing paces here. I apologize. I wanted to cover a wide variety of things. I want to caveat this with a couple things. So disordered eating, body image is very personal to people. It's a very touchy subject. It can be very sensitive to people. So if you at any point in this conversation need to leave the room, need to step out, please do. We will be available to talk after this brief if this brings up any emotions that are uncomfortable, if this brings up any emotions that you want to discuss. So I'm going to do a little activity first. So for this activity, I'm going to have a list of questions I'm going to ask. The idea is that you raise your hand if the answer is yes. If you don't want to raise your hand, you don't have to. No one's obligating you to. I'd like everyone to close your eyes. No one has to look at anybody else. No one can see. But this is a time to reflect inward. This is a time to think about if this is true for you, if you've ever done this in the past. But again, there's some sensitive questions, so if it makes you uncomfortable, you don't have to answer. You can walk out the room. This is a safe space. Okay, so the first question. Have you ever done excessive exercise, restricted your eating, or done laxatives or diuretics to lose weight quickly? Okay, put your hands down. Are you scared that if you don't diet or watch what you eat, you will gain weight? Okay, hands can go now. Have you ever added in certain exercises for the sole purpose of enhancing looks? Hands down. Do you believe yourself to be fat when others believe you to be thin or fit? Okay. Are you afraid to eat certain foods, such as high fat or high sugar foods, for fear that you cannot stop eating or that they'll make you gain weight? Okay. Have you avoided doing certain exercises because they'll make you bulky or they'll make you gain weight? Okay. Are there foods that you've completely cut out of your diet, even though you still enjoy eating them? Okay. Last question. Does looking in the mirror or standing on the scale cause you to drastically change your eating or workout behaviors? Okay. Hands can go down, eyes can open. Okay. Lots of, sensitive questions there. A lot of inner looking. I saw a lot of hands raised automatically, like, oh, yep, that's me. I do that all the time. These are questions that myself, Colonel Story, Captain Pierce, the dietitians at IAC, we all consider when we're talking with soldiers, with patients, in regards to their eating behaviors and their body image, etc. You can go to the next slide. So, disordered eating. Disordered eating is not a clinical diagnosis. These are eating behaviors that do not meet the diagnostic criteria for an eating disorder, and they cannot be clinically classified, but they are just as important to acknowledge and to classify for us as dietitians. So some examples of those behaviors include weight loss dieting, dieting to lose weight quickly, binge eating, so that means eating a lot of food in a quick period of time, maybe feeling guilty afterwards, self-induced vomiting, other purging techniques like excessive exercise. So maybe you had a big meal, the next day you're like, I'm gonna go burn it off and run 20 miles, things like that. Or the use of laxative or diuretics to lose weight. And I'm gonna tell you right now, as a dietitian who sees a lot of soldiers on ABCT or who wanna lose weight, every day somebody's in my office with one of these behaviors. Every single day, male and female. Disordered eating does not specifically pertain to the female population. It's very much across all people, all genders, everybody. Everybody experiences these behaviors at one point. Very, very common in weight control sports and this tactical setting. Next slide. And this ties a lot into body image. So body image is the combination of the thoughts and feelings that you have about your body. They range from positive to negative. You can have both of them at the same time. You can have neither of them. People feel all sorts of ways about how they look, how they feel, how they look in the mirror, how they think others think about them. Positive body image is associated with higher self-esteem, higher self-acceptance, and having healthier outlooks and behaviors in life. We all want positive body image. We all want to look in the mirror and be happy with what we see, be happy with who we are. That's not always reality, right? Those disordered eating behaviors, societal pressure, social media, that's all very real, and that's a very understandable emotion to feel. Body dissatisfaction is that internal, emotional, and cognitive process that's influenced by external factors, such as the pressure to meet a certain appearance or look. Unfortunately, in the military, we have this pressure every single day. I have height weight tomorrow morning. And there's this back part of my mind that's saying, okay, maybe skip dinner tonight, maybe don't eat tomorrow morning, you know, like maybe lose a pound before tomorrow's height weight. And I have to fight that thought back a lot because that's one, not safe, not healthy. It's a sign of disordered eating. And it's taken me a long time to get to that place where I can say to myself, whoa, hold on, let's not think like that. But that's a very common thought many soldiers have in the weeks leading up to a height weight or throughout the entire year. So we have that pressure on us constantly. There's a lot of weight stigma and internalized weight bias there, right? No one wants to be told by a peer, by a fellow soldier that, hey, you know, you're busted out of your uniform, right? Those are really common things that we hear fellow soldiers say all the time. And so with this kind of environment, it's really hard to have that positive body image, that self-acceptance when we're hearing a lot of those things all the time. Next slide. So what can you do? Anyone ever heard of body positivity before? Yes. Maybe some people? Okay, so body positivity, it's a more up-and-coming movement, I should say, but it focuses on positive qualities, skills, and talents that a person has. And it focuses on setting positive, health-focused goals. Weight does not equal health. And I'll repeat that all day long to everybody who comes up to me, no matter who you are. Weight does not equal health. The number on the scale does not define your health, does not define who you are, does not define how you should feel about yourself. There are so many components of health that we talked about today. Strength training, mobility, flexibility, pelvic floor health. None of that has to do with the weight, the number on the scale. So body positivity is focusing on your positive qualities, focusing on how strong you want to be, focusing on preventing injuries, focusing on things that you can control that empower you as a person. Acknowledge that you are feeling uncomfortable in your body. That's a big step in going towards body positivity, going towards understanding disordered eating, is acknowledgement of those feelings, and also talking to somebody about it. It's okay. Many of us have had these feelings in the past. Myself and Colonel Story are educated to talk to you all about these feelings and help you work through them. Taking charge of your health is another big piece of this. So pay attention to how you feel about yourself. Pay attention to how you feel after you exercise, how you feel after you eat. Try to tune in to those emotions, tune into how you truly feel. Do you feel full? Do you feel satisfied? Do you feel hungry still? Do you have negative thoughts about food? Do you change how you eat when you see somebody else who you think is thinner than you, etc. And choose to make some healthier food choices along the way, right? I tied that in because of all the things I talked about earlier, right? Calcium, vitamin D, iron. But we know what's beneficial to the female body, right? Calories, for one, right? That female athlete triad, calories, iron, calcium, vitamin D, and all the things we talked about today, strength training, injury prevention, etc. Choosing to make those choices is taking charge of your health and taking charge of your body. That's things you can control and things that are focusing on the positive qualities in your life. Okay, next slide. Is that a question slide?
It's the last one.
Is that on slide? Okay, I do not have a question slide because I forgot to put one on here. But does anybody have any questions before I hand this off? Yes.
So going back to like the source of meat that we can consume, I see red meat is in there, and I've noticed or I've heard a lot of people are cutting, or females are cutting red meat on their diet. So the first question is, what's the recommendation to replace red meat? And also I've heard red meat causes menstrual cramp. Is it true? And if it is, how can we balance our diet by reducing red meat?
It's a great question. So to answer the second part first, I have not read any research on, and Colonel Story agrees with me, on red meat increasing your chance of menstrual cramps. For a lot of people, it's very individualized. So maybe you have cramps on day 1, maybe you have cramps on day 5, and you feel better when you have hot tea, you feel better when you have a smoothie. So it's very individualized. If you personally feel that red meat doesn't sit well with you on your period, it's very common in pregnancy that meats are the word I'm looking for is not desirable, right? It does kind of puts people off when they're pregnant. You have other options. You can go to a lean meat source if it's red meat that's bothering you, so chicken, turkey, fish. Seafood's always an option. If you're pregnant, you want to make sure all of our meat's cooked through all the way to make sure that you're eating safe products. If you're looking for iron sources, don't forget your plant-based sources like leafy greens in particular. Spinach is a big one. If you're looking for protein, plant-based protein is always a great option. We love plant-based proteins in the nutrition world. So your plant-based protein sources are going to be things like beans, nuts and seeds, lentils, soy products like tofu or edamame, things in that range. So red meat is not a mandatory thing to include in your diet. It's a great source of iron, for sure, but there's other options entirely, and so you do not have to feel like you have to include it. To answer your question, please. Okay. Question?
Yes, what's the best, like, protein supplement for working out and
So the question was, what's the best protein supplement for working out? I guess I forgot to mention earlier, performance nutrition also has to do with supplements. So if you have supplement questions, we're your go-to people as well. Well, I'm going to say this first, food is always better. So if you can get your protein from a food source, always try and do that. Our bodies are meant to break down protein from food items. We know how to tear apart our chicken in our stomach to get protein, so we're good at that. But if you're going to supplement with a protein powder, if you're fine with dairy sources, whey protein is the best option. It's the most absorbed of the protein options. If you don't like whey, you could do casein as well, or egg white protein. And if you're dairy-free, maybe vegan, the best alternative is a pea protein. You're very rarely going to see a pea protein on its own because it's not a complete protein. You might see pea protein with brown rice protein. Those are both decent options. I would finish this off with supplements are not regulated. So if you're going to buy a supplement, make sure it's verified by a third party. Make sure you see a label on it that says Informed Choice, or NSF certified, or USP certified. That's just verifying that that supplement was tested by a third party organization and that they ensure there's no banned substances, the label is correct, etc. Great question. Any other questions before I pass the mic off?
I have a question.
Yeah.
So
I've heard if you actually eat less, you can gain weight.
I was wondering if you knew anything about that.
So the question was, if you eat less, can you gain weight? To be fairly blunt, no. But let me explain my straight up no there. So the general thought is calories in, calories out, which we know is not simple. We know it's more complex than that. There's hormonal balances there, there's activity, there's lifestyle. Genetics play a huge part in these things. But generally, if you want to gain weight, we have to add calories in. Muscle builds, right? When we break down muscle and we tear it apart in the gym, like we're working our chest out, we tear those muscles apart. In order to build them back together, our body has to be in what's called an anabolic state. It has to be in a build state. If we're building, that means we have excess calories to build with. If we have fewer calories, we can't build because we're just trying to pump blood. We're just trying to breathe. We can't build muscle. We don't have enough calories to breathe. So if we want to build muscle, we have to be in a little bit of an excess in order to build muscle on top of that. There is this fine line between losing weight and building muscle. It's a tough line to balance on, and if you're struggling with that, I would highly recommend coming and seeing a dietitian, one of us, or Captain Pierce in 2nd Brigade. We can help you achieve that goal and work you through the obstacles that you're facing. All right, I'm going to pass the mic off to Captain DeAndrea, who's going to talk about cognition.
All right, good afternoon, everyone. I'm Captain DeAndrea, I'm an occupational therapist. I was formerly aligned with Dagger Brigade, but now I'm with 1st Infantry Division. But let's, at first, who knows what an occupational therapist is? Raise your hand. Okay, if you are an occupational therapist, please stand up. My battle buddies are here. Yeah, they're great resources. So I like to start with what occupational therapy is because I think it's not well understood. Back in World War II, they found that it was super important to have a job and a role and an occupation that you care about. And really, over time, it's so true. We have roles and jobs that we care about, and when we can't do them, you have some cognitive dissonance, or you have really some negative emotion when you're not able to do the things that you want to do. So that's where our profession really came from. And the Army utilizes us for cognitive enhancement. So if you're just getting used to your H2F team, you don't know, we're really kind of diving into the mental readiness realm. So this morning we heard so much about injury prevention and the physical domain, and that to me is so important, right, to everybody, and nutrition. But I, like most of my colleagues over here, believe the mind and body are so interconnected. And like modern medicine is catching up with us, that is becoming more well-known and understood. Mind and body are so interconnected. So you cannot be in pristine physical health and have a mental health that's lagging. You cannot really ignore your nutrition or have a bunch of negative emotion there and expect to perform well in the gym. It's just not going to go well, right? So the Army does a good job building in time to physically train in the morning, and I think we're still trying to find ways to make sure we're targeting those other areas that are super important to health. So Captain Eberlein did a great job saying, your weight does not equate to health. There's so many ways that we can say that, right? Your physical fitness does not necessarily equate health. Are they indicators? Absolutely. But that's just a piece of the puzzle. So our last little block of instruction is to hopefully really tie in that mental health piece. And we're actually going to start with a little exercise. So before we progress our slide deck, what I'm going to ask is we're going to play a little game of true or false. So if you think the statement is true, you're just going to stand. And if you think it's false, stay seated. Okay, so the male brain is larger than the female brain. Stand if you think it's true. Okay, sit back down. Females have better memories than males. You think it's true? You can. Okay, I love it. Please sit back down. All right. Males have better visual spatial reasoning than females. Please stand if you think that's true. All right, sit back down. Males and females regulate hormones differently. Stand. All right, you can sit back down. We're only doing a couple more, I promise. So if you're like, man, this lady. All right. Everyone processes stress the same way. Please stand if you think it's true. All right. Men experience more chronic pain than females. Please stand if you think it's true. Okay. Women have more gray matter in their brain than males. And if you're like, what's that? Don't worry, we'll talk about it. So please stand if you think it's true. Okay. Last one. Men have stronger movement pattern connections in motor planning than females. All right. We can progress with slide, guys. So, like Coach Miner did, we're going to spend just a few minutes kind of debunking what the literature says. So there are some anatomical differences between the male and female brain. The first one being size. So the male brain is pretty much widely accepted to be 10% larger than the female brain. However, male bodies and heads are also bigger. So when you account for relative size, I'm not sure that has any impact, right? I would also say it has no correlation with intelligence. So, and like the human species has prided ourselves on that through time. If we really went on brain size, like the smartest animal would be a whale. So, not necessarily are we going to equate that size with intelligence. The next one is females have more gray matter in their brain. That's a fold in the cortices in your brain that allow for cells to communicate. So what that does is it allows for higher processing speed. It's pretty well accepted that females have more gray matter. However, we leverage our white matter more than males. That is thought to be why males tend to prefer and excel at task-oriented, closed-chain tasks, right? That's not necessarily to say that females are good at it, or that we might not prefer them as well, but that is thought to explain why. During pregnancy, you have a reduction in that gray matter that actually accounts for mom brain. That's a pretty natural process with what's going, but it does go back as your hormones regulate. Males have stronger front-to-back brain connections, so that is thought to be involved with motor planning and motor strength and movement patterns, where females have stronger side-to-side hemisphere connection, and that typically lends itself to strong communicators, intuitive thinkers, stronger analytical thinkers. If you look at research, females typically perform better on standardized testing and higher like language-based tests, and they think that maybe that's why. So if you're relating to any of this, this is just kind of what the science says is going on, but really there's been no study.
I'm Captain Andrea, I'm an occupational therapist. I was formerly aligned with Dagger Brigade, but now I'm with 1st Infantry Division. But let's, at first, who knows what an occupational therapist is? Raise your hand. Okay. If you are an occupational therapist, please stand up. My battle buddies are here. Yeah, they're great resources. So I like to start with what occupational therapy is, because I think it's not well understood. Back in World War II, they found that it was super important to have a job and a role and an occupation that you care about. And really, over time, it's so true. We have roles and jobs that we care about, and when we can't do them, you have some cognitive dissonance, or you have really some negative emotion when you're not able to do the things that you want to do. So that's where our profession really came from. And the Army utilizes us for cognitive enhancement. So if you're just getting used to your H2F team and you don't know, we're really kind of diving into the mental readiness realm. So this morning we've heard so much about injury prevention and the physical domain, and that to me is so important, right, to everybody, and nutrition. But I, like most of my colleagues over here, believe the mind and body are so interconnected. And like modern medicine is catching up with us, that is becoming more well-known and understood. Mind and body are so interconnected. So you cannot be in pristine physical health and have a mental health that's lagging. You cannot really ignore your nutrition or have a bunch of negative emotion there and expect to perform well in the gym. It's just not going to go well, right? So the Army does a good job building in time to physically train in the morning, and I think we're still trying to find ways to make sure we're targeting those other areas that are super important to health. So Captain Eberlein did a great job saying, you know, your weight does not equate to health. There's so many ways that we can say that, right? Your physical fitness does not necessarily equate health. Are they indicators? Absolutely. But that's just a piece of the puzzle. So our last little block of instruction is to hopefully really tie in that mental health piece.
And then we're actually gonna start with a little exercise. So before we progress our slide deck, what I'm gonna ask is we're gonna play a little game of true or false. So if you think the statement is true, you're just gonna stand, and if you think it's false, stay seated. Okay, so the male brain is larger than the female brain. Stand if you think it's true. Okay, sit back down. Females have better memories than males. If you think it's true, please stand. Okay, I love it. Please sit back down. All right. Males have better visual spatial reasoning than females. Please stand if you think that's true. All right, sit back down. Males and females regulate hormones differently. Stand. All right, you can sit back down. We're only doing a couple more, I promise. So if you're like, man, this lady. All right. Everyone processes stress the same way. Please stand if you think it's true. All right. Men experience more chronic pain than females. Please stand if you think it's true. Okay. Women have more gray matter in their brain than males. If you're like, what's that? Don't worry, we'll talk about it. So please stand if you think it's true. Okay. Last one. Men have stronger movement pattern connections in motor planning than females. All right. We can progress our slide deck. So, like Coach Miner did, we're going to spend just a few minutes kind of debunking what the literature says. So there are some anatomical differences between the male and female brain. The first one being size. So the male brain is pretty much widely accepted to be 10% larger than the female brain. However, male bodies and heads are also bigger. So when you account for relative size, I'm not sure that has any impact, right? I would also say it has no correlation with intelligence. So, and like the human species has prided ourselves on that through time. If we really went on brain size, like the smartest animal would be a whale. So, not necessarily are we going to equate that size with intelligence. The next one is females have more gray matter in their brain. That's the fold in the cortices in your brain that allow for cells to communicate. So what that does is it allows for higher processing speed. It's pretty well accepted that females have more gray matter. However, we leverage our white matter more than males. That is thought to be why males tend to prefer and excel at task-oriented, closed chain tasks, right? That's not necessarily to say that females aren't good at it, or that we might not prefer them as well, but that is thought to explain why. During pregnancy, you have a reduction in that gray matter that actually accounts for mom brain. That's a pretty natural process of what's going, but it does go back as your hormones regulate. Males have stronger front to back brain connections, so that is thought to be involved with motor planning and motor strength and movement patterns, where females have stronger side-to-side hemisphere connection, and that typically lends itself to strong communicators, intuitive thinkers, stronger analytical thinkers. If you look at research, females typically perform better on standardized testing and higher like language-based tests, and they think that maybe that's why. So if you're relating to any of this, this is just kind of what the science says is going on. But really, there's been no study that has shown there's any impact. The biggest thing I can say that I've found that's pervasive through cognitive themes between males and females are the way that we regulate hormones. You can go to the next slide. So the stress cycle is actually the biggest area that I found differences as I was combing through literature for you guys. Who's heard of the fight or flight response? Most people, right? Okay. So what that is that's your sympathetic nervous system in your body. It's using the hypothalamic pituitary adrenal axis, so the HPA, that generates the hormone cortisol. Most people know it as the stress hormone, right? So that's what's happening there. That happens in both genders. But what happens in males is that response is large. It's usually quick and it's much larger. And females, they found that the limbic system in the brain is also activating. That, if you don't know, is the emotional control center. So that in females is thought to be the caregiver response or an attachment response. So what people much smarter than me are thinking is that that almost lowers or buffers that HPA response, so that big fight or flight response. So a male that's stressed might look more aggressive, right? They might have a larger, quicker reaction, where a female might have a tendency to put someone else above themselves, right? We just might say, okay, I'm gonna suck it up and I'm gonna go take care of whoever else and I'm gonna go do what needs to be done. So sometimes that stress can just look differently. Males usually have more prefrontal cortex engagement, and really why that's significant is that's your inhibitor function, right? So that's inhibiting impulses, where females, if we're pulling in our emotional aspect, and I'm up here, I'm talking to you as a healthcare provider, but also I'm a mom, you know, I'm a wife, I'm a sister, I'm a daughter, I'm all those roles. So for me, I was like, oh yeah. My husband actually pointed this out. When I get stressed, I take everything else on. I'm like, oh, too easy, man, I got it, I can do it for you. Like, too easy, I got it, I can be there. And so for me, this kind of rings true. If you're like, no, that's not me, that's fine too, because the literature really says, even though there are anatomical differences, it's super hard for me to stand up here and say definitively that it's really going to impact function. Next slide. And the reason is this model here. So I warned you all in the beginning that I truly believe the mind and body are so interconnected, you really can't tease them out. And I would say this is why. So we spent a lot of time in this biological bubble here today, which is so great. Like the biomedical model in modern science, so important, right? We've come so far with it, but it's just one piece of the puzzle. Captain Eberlein started to touch on this with body image, but really there's all these sociological factors that play a role. So the way you were raised, how you grew up, what your parents taught you, all those norms, that affects you. That's part of the puzzle. That's who you are. Your psychological state, your mental health, your thoughts, the way that you're transitioning information, that's important too. So it's super hard. It's actually, to me, it's like the nature versus nurture argument, which is age old, right? Or the chicken or the egg. It's like, are females having that larger limbic system engagement because we have been thought to be more emotional? Or is that just what our anatomy and our science is telling us? And really there's no conclusive answer on that. But I love this model, because I think really people usually get good at honing into one of the bubbles. It's where they feel comfortable. And once you start to accept your full picture, that's when you're really gonna bring on that holistic health approach. Like that's, I feel like, where you really start hitting those PRs and you are just, you know, a happier, healthier person. So a really great place to start when you think about this model is create your own list. So if I'm me, you know, I'm gonna write down my biological factors. I'm gonna write down my sociological factors. And then I'm gonna write down some of my thoughts and feelings, and I'm gonna acknowledge all of that as part of my picture. So that, I think, is where you really start to benefit. Next slide. Okay, so all of that, and I kind of skipped over this, but one of the hormones that is very well studied to be processing different in the female brain is serotonin. Who's heard of serotonin? Most of us, right? What does it do? Or not do? Yeah, it's linked with happiness. So it's the primary culprit involved in depression. And like all of this information, some of the anatomical, biological information we have, helps us understand that females are prone to certain conditions over males. So I kind of touched on it with the stress cycle, but females are more likely to be diagnosed with depression, anxiety, chronic pain, where males are more likely to have like violent behaviors, alcohol dependence. They're more likely to struggle with neurodivergent things like ADHD, because again, that prefrontal cortex is just involved in different processes. So the one thing I think we can always take into our control is self-care. And like, it sounds really silly and sometimes it feels selfish, but one thing I know is if you are good at being that person that puts everybody first, and you are always gonna say, yes ma'am, I got that for you, or I can take care of you, then you're coming last. So you're kind of staying in that chronic stress state, and it might not feel like it, because that's like home for you. I think many people really feel like that. But the best way to kind of dig yourself out is to make, and I'm trying to give you key takeaways that hopefully you feel like you can implement today. But if you make a little list, and you write a list of, okay, what makes me happy? What helps me feel relaxed? And then what's gonna de-stress me? That's gonna start to get your brain thinking. And she's not here today, but if you know her, Captain Gina Feeney, she's the occupational therapist with the CAB. she uses the analogy of a menu for self-care, and I love it because I think it's so digestible. So you think of appetizers as quick and easy. They're like those 5-10 minute things you can do. So like on my list, it's always like a cup of tea. So when I've had a long day and I'm home, my husband's like, oh, I can make you a cup of tea. I'm like, sweet, that already feels like a little bit of self-care, right? Your entrees are like your larger passions that you don't always have time to do. It's travel, it's leave, right? It's like shooting, if that's what you care about. It's that thing that I can't be like, oh, I had a bad day, so I'm gonna go do X, because it takes far more planning. So if you only have things in that category, that's not gonna get you through the daily. You have side dishes, which are things you can have on the side that just make you feel happier. So for me, it's like a candle, a scent I like, or like music on in the background, right? And then the last one are desserts. And it can be true dessert, but usually it's like a glass of wine or something you want in moderation. Like those are usually good for like that really bad day when the normal stuff isn't just gonna cut it. Really focusing on that. So you can even write it out and plan that analogy for you, but really what I'm up here to say is like cognition is super important. You can't have like good health without it, but it doesn't matter who you are, male, female, like it really doesn't matter. I think this is where you can really always stand to improve because we really live in a society that cares about production, right? We don't really care about relaxing. We care about getting results. We care about mission. And that's not to downgrade it. It's our major. I know it's important. Yeah, that's really all I got. I would be remiss if I didn't say some of the occupational therapists and some of the officers and even some of the supporting entities in this room really helped me put this together, but also we have a lot of really cool preventative programs, so hopefully you have time to stick around and walk through, but you'll see what some of the occupational therapists here are doing, like Captain Godfrey runs a Building Better Sleep. We didn't touch on sleep in this brief because I didn't have time and really she's the expert, but we also have a chronic pain group, we have a stress group, so we are really starting to try and get at these things, knowing that's a piece of our puzzle and part of health in our body. Next slide. These are just my references. I told you I'd go through the research for you so you didn't have to. Last slide. Anybody have any questions? Okay. All right. That's all I got. Ma'am? Thank you. So, why do you think that we came out here today, planned this morning session of all of these different topics? And why does it matter to you as a soldier? I'm going to give you a hint. Starts with an R. Readiness. Yes, absolutely, readiness. That's a win for the day, right? So as soldiers, we always have to be ready. But do we always feel ready? No, right? We don't always feel ready, but the nation is going to call us, right? When we don't even know. It's not a question of if it happens, it's a question of when it happens, right? And so we have a duty, especially while we're here in garrison, to make sure that we are ready to fight and win our nation's wars whenever we're called upon. And if you are struggling in any of these areas, right, that's why the Army said, hey, we're going to put these performance teams embedded into the brigades so they have quick and direct access. It's better to get after prevention or early intervention than waiting for that 3-month appointment to get into the hospital, right? Because I think we've all experienced that, right? We have an ache or pain, and we're like, hey, I need to go see physical therapy. Great, the hospital's full of great physical therapists, but sometimes there's only a few of them, right? But what if we started getting after that prevention? So at that first ache or pain, you can go see the athletic trainer, right? Or sprain my ankle, and I have to go to sick call, but I can't get into physical therapy for 3 months, right? Well, we have great athletic trainers that can get you back into that fight so much quicker, right? Direct and easy access. So that way, if someone actually needs a shoulder surgery and physical therapy, then they can go to the hospital and get that care, right? So now we have that direct access, right? Or, hey, I gotta see the dietitian or the occupational therapist. The mental readiness is absolutely amazing to me. I'm just, every time one of the occupational therapists talks about that mental readiness, I'm soaking it in. I'm like, oh my goodness. The self-care piece that was on the other slide, that is something I'm just now, in my 15 years of career, plus my time as a civilian, I'm just learning about, and I'm actually starting to do. And when I get to spend time with my
the main entree, which is, for me, it's horseback riding, so I finally got a horse. When I spend time with my horse, even if I don't get to ride, I'm just spending time, I go back home, my husband's like, I love you so much more. Because you got that time to refill, to let your mind at ease. And I feel like I can function better at work when I take that time for self-care, right? And again, I love that menu analogy, because yes, it is easy, digestible, so it's fantastic.
You like the pun man?
I did. I love puns. It's very funny. But hopefully the QR codes work. We can leave this slide up and you can come up, take a picture. Otherwise, just get with one of us. We can funnel you to the right individual. It looks like our box lunches have arrived. So even if you have to bounce and get out and go to your next thing, please take a box lunch. Does anyone have any further questions? Okay. I'd like to bring all of the presenters up, as well as everybody from the H2F teams, because nothing happens on our own. It takes literally a village to do this. We did mention also the R2 Performance Center. We have great relationships with the R2 Performance Center. I see Rachel in the back. I'm not sure if the others are here. Make use of every single resource that you possibly can.